This is the lecture for Unit 3, which is called Global Health and Critical Medical Anthropology, Context and Application. So let's start with a more general discussion about global health, and then we'll move into some of the specific stuff that you've been reading for this week. The general point that I want you to understand is about how health and disease are patterned across the world. What we find if we look at what makes people ill and what they die from in different world regions, we find that the differences in those health and disease profiles are a result of economic and political disparities that lead to health disparities. In other words, people are not being made ill and dying of the same things everywhere. And that difference is not about biology, it's about actually economic and political dynamics. It's about differences in power and access to resources in different regions of the world. So where that comes from has a long and deep history. Just to sum it up in a very sort of basic way, if we think about how different world regions' health manifests, we can see the legacies of colonialism. And that takes the form of poverty, of differences in power in the world, and frankly, ongoing exploitation and cultivation of dependence between particularly the global South and the global North. So that basic set of relationships, that basic set of dynamics informs health in the world, okay? And that is the reason that we find these inequities in sort of how healthy people are and how much access to healthcare people have in different world regions. So another way to think about this is that what is often referred to as the epidemiological transition has not happened consistently across the world. What we mean by the epidemiological transition is a sort of historical transition from people dying from infectious disease to people dying from degenerative disease. Typically, this follows a rise in life expectancy and the advent of various aspects of modern medicine, including things like vaccination, etc., right? So the fact of the matter is that the world has not moved forward in that regard in an equal way across all world regions. So in the global South, we see that people have very different sort of health and disease experiences. There's a much higher burden of disease in general. There is, again, also much less access to healthcare. There's a lower number of biomedically trained physicians. We'll talk more during the course about other kinds of healers, of which there are a lot. But access to biomedically trained physicians is much lower for folks in the global South. Given that prevalence of disease and that lack of access to modern health care, some of the most basic markers of health reflect that, right? So there's low life expectancy and there's high child mortality, two things that are linked. And then we see that the primary causes of death are infectious disease, communicable disease, as opposed to the degenerative diseases that are the most common causes of death in the global North. We'll look at some stats on that in a minute. And then something, again, that we'll talk about later in the course, what we also find is a connection between these health patterns and other causes of or other threats to well-being, particularly political violence and displacement. So the same parts of the world that are struggling with things like low life expectancy and high child mortality, lack of access to modern health care, etc., are also sites where we find increased political violence and a large number of people, for example, living as migrants or as refugees. In general, I think if we look at global health, we can state that there's pretty much been a global failure to to effect healthiness for the world population. And there's been a real lack in general of political will to make that happen, particularly to support the health and well-being of people in the poorer regions of the world. So the dynamic is one that's entrenched. It's related to long-standing historical and political dynamics, and it's not something that has changed despite various calls by international health organizations, etc., to shift that over time. The final point I'll make on this slide is that this dynamic, this inequity between the global south and the global north is something that we see mirrored in inequities within the global north. So it's not just that people living in the poorer regions of the world suffer from this list of health challenges that I have on the slide here. We also find some of those same issues plaguing the poorer parts of the global north, even within global cities like Chicago, where people's health is informed by which part of the city they live in. And again, we'll return to that in a few moments. So I mentioned in the last slide that life expectancy is sort of one of those real basic markers of health and well-being, and it's because it's so broad, it's a way to compare different world regions. If we look at this, this is recent data from the World Health Organization. This is not just life expectancy, but it's a statistic that is often referred to as healthy life expectancy, meaning not just how many years you'll live, but how many years you'll live in a state of relatively good health. And this is, starting from birth, right? So basically, how long of a healthy life can one expect to live in different world regions? And it's pretty obvious if you look at it. The key is over here in terms of understanding what the different colors mean. So the lighter colors on the map are lower life expectancy, and the darker colors are higher life expectancy. So we see something like, Canada and Western Europe is at the highest sort of end of this spectrum with 70 to 80 year healthy life expectancy at birth. If we look at something like the African continent, you start to see life expectancies that are down in the 50 to 60 years range, or even 40 to 50 years, right? So it's fairly clear that there's a differential here in terms of world regions. It's not an accident that we see the entire or most of sub-Saharan Africa in these lower ends of the life expectancy range. Now, all of that said, we can see what we can call progress over time in terms of global health. So this graphic is under 5 mortality, right? So that's the probability of dying by the age of 5 years old per 1,000 live births. So it's what percentage of young children can be expected to die, right? Between the year 2000 on the left and the year 2015, okay? Again, it's the same kind of thing we were just looking at, a heat map. Heat maps like this, where there's like a color coding that shows you patterns, are really useful for just getting a quick visual understanding of inequities in the world and differentials in the world. So, again, here's the key, same key. The sort of darker red and orange colors are increase in that under 5 mortality rate. The paler color here, the white and yellow, is a lower one, right? So again, we're going to start with the year 2000, and we see, an absolutely stark difference. Again, focused on the African continent, the poorest region of the world. But we also see those same sort of higher numbers in Southeast Asia, to some extent in South America, right? But we see those inequities played out. Some in sort of atrocious degrees with some of the red and orange in the African continent. Here we are in 2015 on the right. This is an improved circumstance, right? We see that some of the regions that were sort of in that lower end, they have a less atrocious under 5 mortality rate. However, we still see those same inequities, where some world regions are much more likely to have a higher child mortality rate than others. So we do see improvement on the right. Some of the most extreme differences in child mortality rate have improved over time in this 15-year span, but we still see tremendous inequities if we look globally at these rates. Some of the interventions, global health interventions, have had an effect, but there's still a long way to go. Another example of sort of improvement, but still work to do, is on the percentage of the global population that has access to clean drinking water. Again, comparing 2000 to 2015, these are the numbers over here, and you can see again the African continent and other parts of Asia and South America have considerably a smaller percentage of the population that has access to clean drinking water. It has improved in those 15 years, but there's still tremendous differentials. Likewise, if we look, again, this is data from the World Health Organization. If we look at the different world regions, at the most prevalent causes of death, you can see the difference in what kind of disease is leading to death in these different areas. So here we have the Americas, where the top killers are degenerative diseases, right? So we have heart disease, diabetes, etc. Violence, which is not a degenerative disease, but is something that plagues the world in multiple regions, stroke, etc. In the Southeast Asian region, we see, again, sort of a combination. We have heart disease at the top, stroke. We do have lower respiratory infections at number 4. The European region, again, heart disease, stroke, cancer. These are all degenerative diseases that tend to affect people later in life. In the African region, we find that infectious diseases are at the top of the list. Respiratory infections, HIV/AIDS, diarrheal diseases, etc. So again, this is just to make the point that what people are falling ill with, what is killing people, is not the same everywhere in the world, despite the fact that we absolutely have the medical technologies to both, in many cases, prevent and treat many of these conditions. So that leads us to understand that this is a political and economic issue, not a biological one. I want to take one final example to illustrate this issue of health inequities in global context, and to sort of bring it home and to make the point that it's not just a difference between what's going on health-wise in the global south and the global north, but also there are health inequities within countries in the global north, like the United States. This heat map is representing cervical cancer and demonstrates the degree to which people in Africa are much more affected by adverse outcomes from this, in fact, quite treatable cancer. So cervical cancer is one of the most preventable forms of cancer and one of the most curable. We have vaccination for cervical cancer, and with early detection and treatment, it can be managed quite well. However, what we find is that the rates for cervical cancer are as much as 6 times higher in Africa than in North America. Part of the reason that we see such adverse outcomes is that in many parts of Africa, cervical cancer is not identified or treated until it is at an advanced stage. And therefore, it is harder to help people who are already in that situation And it would be much better to work on increasing effective screening and early treatment. Now, so there's one set of inequities. Now, if we look at a parallel situation, we can look at cervical cancer in the city of Chicago. This is another heat map. And in this one, we see how those global health disparities are paralleled in disparities within the city. So again, you have your key over here, which shows the darker colors are greater percentages of cervical cancer deaths. And as you can see, the south and west sides of the city, we see much greater numbers of deaths from cervical cancer than we do on the north side of Chicago. Again, in a parallel to the global map, what we're seeing here is that people living in poorer parts of the city are more likely to die from this particular form of cancer, just as people in poor parts of the world are more likely to die of that form of cancer. Again, we have the technology to screen for and effectively treat this cancer. It's only by virtue of people's political and economic circumstances that they are more likely to die from it. We have an example of global health inequities right in front of us, in fact. As all of us are thinking about and experiencing the COVID pandemic, one of the most pressing issues right now is vaccination. And I'm sure you've all been hearing a lot about the importance of getting vaccinated, since it's one of our primary sort of tools to confront this particular pandemic. One of the things that we can see, particularly with the Omicron variant, is that the rates of people getting vaccinated are not equally distributed across the world. And in fact, that has contributed to the rise of variants like Omicron. So I wanted to show you a little bit of data here that was just very recently compiled. This is data from the beginning of January 2022. And what it shows is, let me scroll down here to the rates at which people are getting vaccinated. And it's not because of folks refusing to get vaccinated. It's just access, right? So if you see, again, darker blue is a greater percentage of people who have been vaccinated. This particular statistic is people with first dose vaccinations. Lighter is a lower rate of vaccination. Again, we see the poorer parts of the world, lower rates of vaccination, particularly the African continent. If we actually look at the data here, this is the percentage of people with a first dose. This data is from January 3rd. So just very recently. And we can see much of the world is in the 70s, 60s, 50s, Central Asia down into the 40s, the Middle East and North Africa 40%, and then Sub-Saharan Africa is just over 10%. So a tremendous drop. And this is precisely because of lack of access to vaccines. So the rise of variants like Omicron is not just about the evolution of the virus, it's also about lack of access to vaccines and lack of vaccine equity. One of the African Union's COVID-19 vaccine task force members tweeted when Omicron emerged. She said, "We advocated, begged, pleaded that high-income countries share doses, support TRIPS, which is releasing the vaccine producers to we advocated, begged, pleaded that high-income countries share doses, support TRIPS, which is allowing for vaccine production, and local production of vaccines on the continent. They largely refused. This was inevitable but completely avoidable. Travel bans are not the answer. Urgently vaccinating the world is. So again, we see how health, particularly global health, we look at these patterns, is not just about biology, it's also about political will and having the power to claim these resources when they're needed. So when we think about global public health, part of it is those political and economic dynamics, the relationships between governments, et cetera, that we've just been discussing. Another role in all of this is that of public health itself as a field. One of the things I had you read for this unit is an article by Richardson, in which Richardson argues that public health is partly to blame for some of these health inequities that we see. What Richardson argues is that public health is, in some ways, quote, an accomplice to contemporary imperialism. That is, that public health reinforces colonial relationships and power dynamics. What he calls this is a framework of bourgeois empiricist thinking. It's a notion that stresses a sort of scientific objectivity about health that erases some of the historical and socio-political contexts of where health comes from. And this sort of commitment to objectivity, he says, is part of the way in which public health supports and is indeed sort of part of what he calls coloniality. So in other words, public health ignores certain variables that are crucial to understanding why people are ill and what needs to happen to make them well. He suggests that scholarly journals are part of this sort of regime, if you will. They reinforce this narrative of an objectivist, scientist, sort of oriented public health, and remove any context for these other explanatory frameworks. Richardson holds out hope, though, that we can transform global health by transforming these representations. The example that he uses in this article is about the Ebola outbreak in the Democratic Republic of Congo, where, as he notes, there was sort of a media and public health narrative about the problem being individuals on the ground who were spreading Ebola because of their mistrust of public health measures, engaging in activities that were referred to as super spreader events, etc. What this approach or this narrative misses, Richardson suggests, is the historical and political context of why people have a very good reason to distrust public health. And the idea that, in fact, some of these so-called conspiracy theories are actually critiques of that colonial context, right? So what Richardson suggests is that there's a different way to look at local people's narratives about health and about the sources of ill health. And that if we look at those local narratives, we'll see that these stories about public health are sites of contestation, that there are power struggles about who gets to control the message and who gets to place blame where. So, for example, in the case of the Ebola outbreak in the DRC, there was a study that demonstrated that people in that region who had been subjected to colonial medical campaigns in the past were more likely to distrust public health interventions in the present. So again, understanding that context is crucial to understanding how to move forward with public health measures. The other piece that I had you read is by Seth Holmes. It's from a book called Fresh Fruit, Broken Bodies. And his book is about migrant laborers, people who cross the border from Mexico to the U.S. to work particularly in agriculture and as seasonal workers. And this is, Holmes is a medical anthropologist So he's really interested in the health aspect, but also that sort of social context, and thinking about the kinds of suffering that these migrant laborers experience. His approach looks at suffering broadly. So he's interested in, yes, in the sort of physical ailments that accompany this kind of labor, but also the mental and existential and interpersonal suffering. He draws on a theory that comes from two medical anthropologists named Scheper-Hughes and Bourgeois, about thinking about violence as a continuum. So certainly some of the more obvious forms of violence, physical violence, political violence, are important to take account of and to address. But he adds to that an idea about structural violence, that is, embedded dynamics that inform people's well-being, as well as symbolic violence and everyday violence, some of the more sort of implicit forms of violence that are not often recognized as such. So the piece of this book that I had you read is a book about migrant laborers' experiences going to clinics. He describes in the book how this kind of work is really taxing on people's bodies, as well as on people's psychological well-being and their social well-being. So in this particular chapter, you learn about sort of what's going on in these clinics. And one of the things that Holmes brings to bear on this is a cultural anthropological approach to biomedicine. That is, cultural anthropologists have a different sort of critique of biomedical practice than you would find coming, for example, in a medical journal. And the anthropologists bring certain kinds of theoretical tools to bear on this question. These theoretical tools are some that we're going to talk about in more detail later in the course. But just briefly, one is from Arthur Kleinman, a medical anthropologist who has written extensively about the importance of illness narratives, taking seriously how people talk about how they experience illness. Byron Good, who you'll read a couple of pieces from, who has written about the clinical gaze, that is, how biomedically trained physicians view their patients, and what that sort of viewing of patients means for the practice of medicine. One of the other theorists that Holmes mentions is Michel Foucault, who's not an anthropologist, but is a theorist who has informed lots of fields in the social sciences and humanities, including anthropology. And one of the things that Foucault notes is sort of the historical transformation of medicine and the sort of origins of that medical gaze that Good also talks about. Foucault notes that that lens changed in the 19th century, at which point medical practitioners started to focus on body parts and thinking of the body as a sort of an individualized entity, right, that can be dealt with almost like a machine. A shift that Foucault suggests included a certain amount of depersonalization or dehumanization. So in other words, illness ceased to be understood in its social context and instead was looked at as an individual phenomenon in that body, in that moment. And sort of the famous image of early dissection of cadavers is sort of an indicator of that shift to thinking of the body as something separate, really, from the person and from the social context in which that person existed. So Holmes applies this set of theoretical tools to thinking about, again, that concept of the medical gaze, the way that physicians look at the individual body in the clinics where these migrant laborers go. And he gives us several specific case studies, 3 individuals, and talks about what they encountered in that migrant clinic. And what they encountered, I think, says a lot about the nature of biomedical practice and the power dynamics that are inherent in that social space. So, what these patients experienced was a lot of blaming the victim, right? The sort of narrative that they don't know how to work properly, that they don't know enough about their own bodies, that there's too much sort of commitment to traditional cultural beliefs, and that's part of the problem. There were all kinds of linguistic barriers. Patients in these migrant clinics didn't have necessarily access to interpreters. A lot of things were done in English, even though that was not the language of the patient. There were various other assumptions about patients, including assumptions about high rates of domestic violence, the idea that the patients were trying to get away with something in some way, and the notion that they were simply different in a bodily way by virtue of their ethnic background. There was a valuing of the objective perspective of the physician over that subjective perspective of the patient. Back to that idea that we'll again talk about later of illness narratives, that it's important to understand how people actually experience illness. On the other hand, as Holmes also points out, the health professionals themselves were also being pressured. They were working within a neoliberal health system. There was often a lack of funding, a lack of materials, and they had to struggle themselves to provide care. In the end, ultimately, there was an individuation of suffering, right? So a lot of both the understanding of the nature of the illness that these individuals were bringing and the appropriate treatment dealt with them as individual bodies, not with the understanding of the social context in which they were living and working. Holmes' take-home message here is that biomedicine has a tendency to depoliticize health and illness. So Holmes, as both an MD and a cultural anthropologist, is engaging in a sort of critique of the field of biomedicine. It's not saying he doesn't think we should have it, but that there are all kinds of cultural assumptions and cultural frameworks, as well as power dynamics embedded in biomedical practice that come out in certain ways, particularly in this migrant clinic. So this is our lecture for this unit. So I hope you enjoyed the readings. Keep at it, and we'll talk again soon. Bye-bye.